All right, let's talk about something really critical in the ICU, something that every single one of us has to deal with: ventilator-associated pneumonia, or VAP. This is a huge deal for our sickest patients, and it's something we all have to get right. So let's dive in.
So, picture this. You walk into your ICU shift, you're looking at your patient on the ventilator who's been pretty stable, and suddenly they have a new fever. And you notice their oxygen requirements are creeping up. What's the first thing that should pop into your head? In this classic scenario, VAP should be screaming at the top of your differential diagnosis. Let's break down exactly why. So here's our game plan. We're going to start by defining what VAP is and why it's such a threat. Then we'll cover the signs, what it looks like at the bedside. After that, we'll walk through the steps from just suspecting it to actually diagnosing it. Then comes the main event, treatment and how to do it fast. And we'll wrap it all up with the key takeaways you can bring with you to your very next shift. All right, so first up, let's really nail down the basics and build a solid foundation by defining VAP and figuring out its place in the universe of hospital infections. Okay, so what is VAP? The definition is actually all about timing. That's the key right there. It's a lung infection, a pneumonia, but the clock starts after they've been intubated for more than 48 hours. This isn't something they came in with. It's a direct complication of being on that breathing machine. That 48-hour window is everything. And look, this is not some rare zebra diagnosis. We're talking about 10 to 20% of patients on a vent for more than 2 days. That's huge. That means for every 10 patients you have in that situation, 1 or 2 are likely going to get VAP. It just goes to show how common and serious this problem really is in our ICUs.
Okay, so let's clear up some alphabet soup here, because it can get confusing. VAP is really a specific type of HAP, hospital-acquired pneumonia. The big difference? The ventilator. And you might notice we've ditched the term HCAP. Why? Well, it turns out it was just a terrible predictor for who is going to have those nasty multi-drug-resistant bugs. So now we keep it simple: VAP and HAP.
Okay, so we know what it is, but what does it actually look like at the bedside, right? What are the red flags you need to be watching for? Thing is, VAP isn't usually just one single sign. It's more of a pattern, a constellation of clues. You're looking for a change from how the patient was doing before. All of a sudden, they've got a fever. You look at their labs and their white count is either shooting up or, maybe even more worrying, it's crashing. And you'll see it in their secretions. They get thicker. They look like pus. But the big one, the one you'll notice on the monitor, is that their oxygenation is getting worse. You find yourself having to crank up the FiO2 or bump up the PEEP just to keep their O2 sats where they need to be. But all those clinical signs, they're not enough on their own. The absolute, without a doubt, cornerstone of this diagnosis is the chest imaging. You have to see a new spot on the lung, a new infiltrate that's either getting worse or just sticking around. And here's a little pro tip for you. If you see something called air bronchograms, where the little airways look like dark tunnels running through a white, hazy lung, that is super specific for pneumonia. It's a really strong sign. All right, so you're suspicious, the patient's clinical picture fits, the x-ray looks bad. Now what? How do we go from "I think this is VAP" to "I know this is VAP"? It's a pretty straightforward 3-step playbook. First, you put your clinical suspicion and your x-ray findings together. That's step 1. Step 2, and this is so important, you've got to get a sample from deep down in the lungs to figure out what bug is causing the trouble. And then step 3, you send that sample and some blood work off to the lab. You need that gram stain, you need that culture, so you can get a positive ID on the culprit. So let's get into the nitty-gritty of what you're actually ordering. You're going to get a CBC with a div to check that white count. You'll send off blood cultures, and don't be surprised if they're negative. They're only positive in about 15% of cases, but you still have to get them. A chem panel to see what's happening with their organ function, and of course, that super important lower respiratory sample. And hey, if you're worried about acidosis or their oxygenation is really tanking, an ABG is a great idea to get a more precise look. Okay, now for the part that really matters, treatment. This is where the clock is ticking, and I mean really ticking. Every single hour counts. And your first choice, that initial empiric antibiotic regimen, is probably one of the most critical decisions you will make for this patient. And this right here tells you why. This isn't academic. This is life and death. The data is absolutely undeniably clear on this. If you mess around and delay getting the right antibiotics on board, your patient's risk of dying goes way, way up. It's that stark. So, you're standing there, about to put in orders. Your very first critical decision is, does this patient need coverage for MRSA? methicillin-resistant Staph aureus. It's a nasty bug, a common cause of VAP, but you also don't want to throw vancomycin or linezolid at everyone if you don't have to. So, how do you make that call? Well, you don't guess. You use a checklist of risk factors. You ask yourself, has this patient had IV antibiotics in the last 90 days? Are they in septic shock right now? Did they have ARDS before the pneumonia started? Have they been laid up in the hospital for 5 days or more? Are they on any form of dialysis? If you can check yes to any of those boxes, or if your own ICU is known to have a lot of MRSA floating around, then you absolutely have to cover for it, right out of the gate. Okay, decision 1 is done. Now for critical decision number 2. This one's about another bad actor, Pseudomonas, and all its nasty gram-negative cousins. The question here is one good anti-pseudomonal drug enough, or do we need to hit it with a 1-2 punch? Do we need double coverage? So, what clues you in that you might need that double coverage? Well, take a look at this list. Does it look familiar? It should, because the risk factors for these multi-drug resistant bugs are the exact same ones we just looked at for MRSA, so it's actually pretty easy to remember. If your patient has any of those high-risk features, the guidelines are clear. You start 2 different drugs that hit Pseudomonas on top of your MRSA coverage. In this chart, this shows you exactly why we're so paranoid about these particular bugs. Look at the data. Pseudomonas is the undisputed king of the hill, causing over a quarter of all VAP cases. And who's right behind it? MRSA. Between just those two, you're looking at almost half of all infections. Then you've got other tough ones like Acinetobacter and Klebsiella. This is your most wanted list. These are the guys you're targeting with those initial antibiotics. So when you decide you need that double anti-pseudomonal coverage, what are your options? This table lays out the main classes, but here's the most important rule. You have to pick 2 agents from different classes. You can't just pick 2 beta-lactams. The whole idea is to attack the bacteria from 2 different angles. So you might pair up a beta-lactam, like Zosyn, with a fluoroquinolone, like Levaquin. It's about strategy. All right, so you've started the right drugs, the patient is finally starting to turn a corner. How long do you keep the antibiotics going? Well, for most people with vape, the magic number is 7 days. The goal is to always use the shortest course that we know is effective. Get in, kill the bugs, and get out. It's better for the patient, and it helps prevent future antibiotic resistance. Whew, we have gone through a ton of information. So let's take a breath and boil it all down to the absolute must-know take-home points for managing VAP. Okay, if you walk away with anything from this, let it be these 5 principles. Number 1, suspect early. Your patient on events starts getting worse, VAP should be on your mind. Period. 2, diagnose systematically. It's a puzzle. You need the clinical picture, the x-ray, and the microbiology to solve it. 3, treat promptly. The clock is your enemy. As soon as you suspect it, start the antibiotics. 4, cover wisely. Don't just guess. Use your patient's risk factors and your local bug patterns to make a smart, educated choice. And finally, number 5, de-escalate. As soon as those culture results come back, narrow your antibiotics. Target the specific bug, and stop the broad-spectrum stuff. This is the heart and soul of great VAP management. You know, we've spent all this time talking about how to diagnose and treat VAP, and that's obviously super important. But it brings up one last really big question. We know all the risk factors, but what's the one we can actually change? What's the single most effective thing we can do to prevent VAP from ever happening in the first place? Chew on that. Thanks for tuning in.